Hello, good evening. Today I would like to present my case study. My title is the clinical evaluation of finding and management of the patient with the tension pneumothorax. This I go through during my presentation today. Okay, first I like to introduction my topic. Tension pneumothorax in medical term, the accumulation of the hair in the pleural cavity, which contain the cavity bound by two pleural membranes between the lungs and the chest wall. As the collapse in the pleural cavity can occur, the result of gap formed by the injury to the chest wall or tear in the lung tissue. So later on I go to the normal lung versus collapsed lung. Normal lungs look like a different shape, and collapsed lungs will be easily displayed between the normal lungs. Symptom usually occurs when the child's chest pain or shortness of breathing. Could be the life-threatening also events can be like happen to the lungs also. Next, I would like to differentiate the pneumothorax, closed, open, and tension pneumothorax. Closed pneumothorax when air goes in the pleural space without any outside the wounds. Normally, the closed pneumothorax, no any the wounds happens, will be the differentiate inside the lungs. Open pneumothorax normally having the wounds. When it occurs, our lungs will be deflated. It could be the like a shortness of breathing or chest pains. Tension pneumothorax is a life-threatening condition that develops when air is trapped in the pleural cavity under the positive pressure, displaying the medicinal structure and comprising cardiopulmonary functions. This is differentiate closed, open, and tension pneumothorax. Today my topic is the tension pneumothorax. I will focus on tension pneumothorax. Okay, first I like to go to the general health history. During my clinical posting, having one patient, a male age of 30, come to the emergency department with a complaint of shortness of breathing, especially when he inhale and exhale. Other symptoms such as like the difficulty of breathing, sometimes fainted, pale, easy and fatigued, and heartbeat is very fast. It's like a tachycardia. Based on my history taking, this patient involved accident 5 years ago, got a chest trauma. After the accident, the chest occurs on the chest or lung was. After that, once he recovery and discharge, then it's getting worse when active in the rugby. Normally, my patients active in the sports. During his sportsman occurs during a rugby, normally become a scum or tackling the player. Normally, the chest will be pain for him. Later on, we just taking the clinical history. After that, done the X-ray, damage the structure around the lung, causes air leakage into the pleural space. During the assessment finding, in the investigation of clinical radiology, chest radiography indicated a previous sided pneumothorax. So once a clinical diagnosis happens, we insert a 40G intravenous cannula into the second intercostal space in mid-clavicle line. Unmistaken, it's called murmur sounds like air. The needle was removed. And after that, patient condition quickly improved, oxygen stable in 99% to 100. Later on, the vital signs was stable. Intragastric cylinders was embedded and the patient was moved to the emergency unit. It tragically passed around the 30 hours after the admissions. A posterior surveillance uncovered the reason of the correct pneumothorax was a crack and bullet. The reason of the death was a cerebral hypos harm. To evaluate for indication of the respiratory trouble, including expand respiratory rate, dyspnea and withdrawals. On lung auscultation is clear. Dyspnea, breathing or some replacer slide, decreasing material famous, hyper-resounding and precaution signs. Indication of the pressure pneumothorax are more serious. With the strained pneumothorax, patient will have an indication of hemorrhagic unsteadiness with hypertension and tachycardia. Cycles or jugular venous distance can likely be viable. In serious cases of the diagnosis for means, patient can create acute respiratory dyspnea, perhaps heart failure in case subcutaneous epidemic are likely to be seen. The diagnosis of the pneumothorax must be properly through the clinical appraisal of the type of imaging, if not previously accessible, may postpone management and increase morbidity. Based on my case, during the we need to make a confirm the diagnosis, we need to do some investigation, such like for tension pneumothorax, normally we need to do the radiology. chest X-ray is really important to confirm our diagnosis. Based on the clinical experience of the patient also, sometimes we can confirm, but to accurate our diagnosis, we must do the clinical investigations such as radiology. Radiology is very important to our tension pneumothorax cases. At the point when patient high-risk study, radiology assessment is suggested. The underlying appraisal is with chest radiation chest to affirm to the diagnosis. Chest X-ray can notice at least one of the economy. A major line speaking of the age, inflatis pleura, distortion of making and distorted lines, complete replacer lung breakdown. Subcutaneous hypertonias, tracheal deviation is the contrast the size of stains of pneumothorax. Smooth or hemorrhages or repeated size of stains of pneumothorax. Emergency management of the patient. Tension on traumatic pneumothorax are normally overseen in the medical officer of the emergency unit or assistant medical officer also. Management techniques rely on the hypodynamic soundness of the patients. In any patient during a chest injury, evitation route, breathing and dismantling should be the survey. Inflating the chest wound must be covered with a seal or shut across the street and some spoilers and plastic sheeting. Organization of 100% supplement oxygen can be helped to device signs of pneumothorax or diminishing the alveolar nitrogen or fractional height. Normally 100% oxygen the patient can be intubate or oxygen face mask giving the 100% oxygen during the pneumothorax. Sometimes the patient can be difficult to breathing also. So that's why we must give 100% oxygen to the patient. This makes a dispersion of angle nitrogen allows this quickening the goal of pneumothorax. Without oxygen, just 1.25 of the air invests in 24 hours. Positive rate of ventilation should be keep away from the first as we die expanding the signs of the tension pneumothorax. Patient can be on the certain weight ventilation after the chest tube is placed. Patients that require careful the meditation are normally patients with a two-sided pneumothorax. Repetitous pneumothorax, first interaction is quite wide with high hazard, calling the pilots or drivers patients who have the debilitation or air spoil. During the video had the thoracic surgery, pneumothorax is treated with a pleurosis. There's a two source of pleurosis mechanism or substance. With the mechanical pleurosis, there's an under 5% possibility of repeat or pneumothorax. A few underdiagnosed are getting the captures dry dressing or repairing of the parietal pleura. Compound the pleural allergies incorporating a powder, micronizing, doxorubicin or antibiotic medications. Substance of pleurosis is another option if the patient can't endure the mechanical pleurosis. Ongoing examination have indicated the pleurosis can reduce the pace of the repeat. During my case, there's a differential diagnosis or intubation of the patients. Differential finding of pneumothorax including pneumonia embolism, acute coronary condition, acute orthotic depression, myocardial dead tissue, pneumonia, acute pericarditis, rib crack, diaphoretic wounds, oesophageal fit, or contractitis, osteochondritis, something like that. Focus attention on pneumothorax must be a deal with the quickly to dodge additional related glimpses and mortality. Postpone in the diagnosis management is related with helpless anticipation. Tension pneumothorax emerges from numerous causes and acutely advanced of the respiratory infection. Cardiovascular is breakdown and the last dimension is not previous at treated. In simple pneumothorax, repeat can occur inside half year to 3 years. Repeat more normal in smokers, COPD patients, and AIDS patients. Inconvenience pneumothorax, partially tension pneumothorax, lethal inconvenience that can happen because of pneumothorax can be because of cylinder tracheotomy as a flow. Respiratory disappointed of heart failure, pneumonia pericardium, pneumoconium, hemothorax, bronchocondylar fistula, harm to nuclear spec during a tube tracheostomy, ongoing skin contamination, and the site of cylinder tracheotomy. Following the photos should be the ready while overseeing the such patient. Thoracic specialists, pulmonologists, interventional radiologists, and pneumatics. Prevention and patient education. Following pneumothorax, patients should be tough to dodge air travel until the complete goal for at least 14 days after the careful intervention. Scuba jumper and pilot must be promoted not to the plug of trial until the complete goal of pneumothorax by the pleurosis of tracheotomy. Smoking discontinuity is encouraged to all the patients. Pearl or other issues. In the event a patient hemodynamic temperature is a high clinical dog for the pneumothorax, needle discompression or tracheotomy tube must be set right away. One of the chance the patient is steady at the point indicating imaging such as chest X-ray should be a possible approximating tremor. Cardiovascular tamponade can clinically imitate a tension pneumothorax. Patients with high clinical inspiratory rate are more serious danger of tension pneumothorax. On the worst chances the patient become hemodynamic shaky or have a heart failure. There's a high doubt of tension pneumothorax. On the other chance there's a chest tube mispoiling or gets stopped. It can stop to work or pneumothorax can repeat. In stable patient, maybe by sedation or stationary absence of pain or sedation should be directed. Needle discompression or tension pneumothorax. It should be impressive to have the best possible heart rate close by the effective play or needle decompression. The most recent information recommended that the needle for use a treatment of tension pneumothorax in go up the patient or 3.25 inches or 14 measures or bigger distance across the needle. Notwithstanding the present instructed, the practice might be effective in the future treatment of a tension pneumothorax. Those the practice utilize 1.75 to 2 inches 14 to 16 measure needle of chest decompression. Notwithstanding the later investigation demonstrating that this needle length won't give the ideal concentration to the patient with the tension pneumothorax. Perform needle decompression for the tension pneumothorax, guarantee the patient is oxygenated if possible. Clean side of the leukemia or provide arrangement, tune it for surgeon or leaving air from the needle, screen or at the point of recoiling the patients. As last, my conclusion, diagnosis and management of traumatic tension pneumothorax requires an elevated level of participation among the multi-division and suppressor. The idea of the assessment of early meditation, deepening mortality and awakeness. In this circumcision, the care coordination is fundamental, having a distinct of callings and prepare to the act. Intensity of life sparing. The main line of responses when the patient will have a traumatic or tension pneumothorax, fluid or contingent after the circumcision and basic etiology. On account of injury, this normally occurs outside the clinic or in the emergency division. In these cases, emergency clinical specialists or emergency department attendants the supply have a function of preventing the ailment quickly and starting early interventions. So based on my clinical studies, even though we are working in the emergency department, trying we must be a pro with a basic history taking. If a history taking failure means sometimes the patient life also threatening condition also. So history taking is very important to determine the patient go to the which zone, or red or yellow or green. Then we can be a save the patient life. That's all my slide. Thank you.